Hey everyone, my name is Alex and I'm a student in Tulane School of Medicine Pathologist Assistant Program, and today I'm going to be talking about squamous cell carcinoma of the lung. So SCC, that's what is coined as squamous cell carcinoma, and the subtype in the lung is a type of non-small cell lung cancer, and it accounts for 25 to 30% of all non-small cell lung cancers. The other types that are in this category would include adenocarcinoma, large cell carcinoma of the lung, adenosquamous carcinoma of the lung, a carcinoid tumor, mesothelioma, and then metastatic primary cancer of just other types of cancers that metastasize to the lung. And then so those are all lumped into one category as non-small cell lung cancers. And then you have your small cell lung cancer, which is a pretty aggressive form of lung cancer. It's typically found once the patient has like pretty large disseminated disease, and it's usually found close to end stage or either at autopsy. So what we're talking about today is squamous cell. It's the second most common type of lung cancer right after adenocarcinoma, and it just typically arises because of repeated damage to your pseudostratified respiratory epithelial cells, which leads to metaplasia, and the cells then change to squamous cells. And with metaplasia, the cells that were once standing up in like a rectangular fashion, and they were right up next to each other with the cilia on top of them to kind of move that mucus out, now they're turning into these flat, like egg, kind of like an egg yolk. If you can imagine like what an egg yolk looks like in a little pan, now they're sitting like these little egg yolk squamous cells and stacking up on top of one another in a metaplasia to dysplasia to squamous cell carcinoma in situ, and then eventually into squamous cell invasive. So with this type of cancer, it does have a strong association with tobacco use. And so it's commonly found that the damage is right there in the center of the lungs arising from the bronchi, right there near the hilum. And because smoke typically rises once it gets into the lung, some of the tumors can be found high in the apex. So epidemiology, and this slide it kind of covers not just squamous cell, but lung cancer in general. Lung cancer is the leading cause of cancer-related deaths in the United States. There was a prevalence peak of smoking in the 1940s and 50s, followed by a peak in lung cancer in the 70s. So that kind of, raised a big alert that, hey, we're doing something that we shouldn't be doing. We should probably look into this. And then in the developing countries, lung cancer deaths are second to breast cancer and prostate cancer, respectively, for women and men. So those two cancers, take a frontline place in front of lung cancer, but it doesn't mean that it's not still prevalent in those other developing countries. The incidence of mortality has fallen since the 90s in both the US and in the UK. And a lot of that has to do with tobacco control programs, laws on smoking, increasing the age for purchasing cigarettes, and also just increasing the taxes and the price of cigarettes. There is a lower incidence of lung cancer in some countries like Brazil, Russia, India, China, and South Africa. But unfortunately, even though they have less prevalence of lung cancer, they have a higher mortality burden. And these for reasons can be unequal access to care, environmental contamination, or social cultural barriers. Prior to the 1990s, squamous cell carcinoma in particularly was the highest histologic type in the United States, but adenocarcinoma has risen as the first place as far as histologic types now. I think it's about 45% of lung cancers are adenocarcinoma, and those are common in women. The relative risk of developing lung cancer for a smoker versus a non-smoker is 10 to 30 times fold. And also, once we kind of noticed that there was a direct correlation between smoking and lung cancer. In 1964, the Surgeon General had reported that 52% of American men and 35% of American women were smokers. And now today in 2018, that has reduced down to 16% of men and 12% of women. So some progress has been made, but maybe just not enough. So risk factors for developing lung cancer. Of course, individual cigarette smoking is the number one cause. Nicotine itself is not carcinogenic, but there are many as 55 substances in cigarette smoke that have been deemed carcinogenic. And then passive smoke inhalation, so that secondhand smoke that you can be around even if you're not smoking yourself. Residential radon, which I personally wasn't too familiar with, but radon is a colorless and odorless radioactive gas that is formed from the ground. So it can seep into the lower floors of your home and get into your drinking water. And it's the second leading cause of lung cancer, which again, I was not that aware of. So you can get home kits that can test for this, and that's a pretty easy way to know if you have radon exposure in your home or not. There are also things like occupational exposure, so polycyclic aromatic hydrocarbon exposure. This is common in like vinyl workplace, a lot of different paints, like working at a car paint shop or something like that, and then benzene. Also, genetic susceptibility or P53 mutation and infection or being a part of the minority population. Symptoms of having lung cancer can range, but you're going to have a constant cough. It won't be immediate, but it's usually whenever that respiratory epithelium starts to really degrade down and you don't have really any cilia anymore to move that mucus out of your airway. Shortness of breath, wheezing, hoarseness. So with the hoarseness, if you have a tumor in the apex of your lung and it's kind of protruding out, it could start to impinge on your recurrent laryngeal nerve, which is a nerve that then innervates your larynx, and your larynx is where your voice box is. So if you think about it, you have a tumor that's kind of growing in the apex of lung. It's inhibiting this nerve to do what it needs to do, and so you can start to lose your voice. Fatigue, trouble swallowing, and this one, because the tumors tend to be centrally located or either growing up into the bronchus, it can start to also give a little bit of impingement like back there on the esophagus. Chest pain, poor appetite, and high calcium in the blood. So many lung cancers have the ability to secrete different chemicals into the bloodstream, and this can lead to abnormally high blood calcium levels. So for diagnosing, there's a few things that you can do, starting from a lot less invasive into more invasive procedures. So a sputum sample, you're really just like looking in the mucus for cancer cells, and then you kind of get up to a biopsy via bronchoscopy. This can be done typically in an outpatient setting. A tube is inserted through the throat with a camera to just remove like a small piece of tissue with these little prongs. You can also do a fine needle aspirate, which is a needle insertion into the lung or the pleura via guided imaging as well. And then they remove just some cells and put it in like some saline fluid, and then they'll send it over to cytology for a cytologist to look at any abnormal cells. You can also do thoracentesis if there's fluid around the lungs, and then of course a CT scan or a bone scan if you suspect late disease or there's metastases. Special stains or immunohistochemistry that specifically distinguish squamous cell carcinoma from other types of cancer are P63, CK5 and 6, and EMA. And this might seem, if you're not familiar with IHC, you're like, what in the world is this? But basically, there are certain stains that'll stain for certain cancers. And so if you do a lung biopsy and maybe you can't quite tell histologically what the cancer is because it's just like really funky histology slides, or just the tissue is just very scattered and you just really can't make a good call on it, you can use immunohistochemistry stains to distinguish if it's squamous cell versus adenocarcinoma. And so the two things that it's negative for on here, vimentin and TTF1, those would be positive in adenocarcinoma. The special stains for squamous cell carcinoma are looking for keratinization and intercellular bridging. You wouldn't normally see that in the H&E. And then for adenocarcinoma, typically in the H&E, you're going to see like mucin production and acinar or tubular structures. So how do you treat this? Well, you could do nothing. You could do something, someone that's not eligible for surgery, if they're very old, if they're not fit for surgery, or if their disease is too far gone or too progressed, they could just do chemotherapy and radiation, and that would do things like reduce the symptoms. It might help with pain. It might help for any disease progression farther than what it currently is. But if a patient can go to surgery, you could do things like a wedge resection, which is what the picture is up here. A wedge is going to remove like a small triangular portion of lung tissue. So think of like cutting out like a little pizza pie, like triangle part in the lung. So you're going to have staple lines on either one or two sides of it. You can do a lobectomy, which is going to remove one lobe of the lung. So the wedge resection is typically going to be for a tumor that's kind of small. A lobectomy, you're moving up to maybe a tumor that's a little bit bigger, and you can just remove the whole lobe. So on the right lung, you have 3 lobes: superior, middle, and inferior. And on the left lung, you have 2 lobes, just superior and inferior. You can do a segmentectomy, so you have 10 segments that separate your lung. And so if you want to just, wedge out a part of a segment because each segment has its own blood supply, you can do that. Or a pneumonectomy, that is going to be removing the entire lung, which is going to have to be followed with a lung transplant. Gross presentation of these tumors, like I said, they typically arise near the hilum or the apex of the lung, like centrally. They're gray or white, usually have some central necrosis or cavitation, so it's kind of just like caving in on itself. They're typically firm and they can cause obstructing atelectasis, but you're going to find them invading into the bronchi or hilar lymph nodes just because of the nature of this is occurring, because you're getting damage in the bronchi. So how do you gross these specimens? Well, if you get the wedge resection, like I was saying, with the little pizza pie shape with the staple lines, you're going to want to measure the specimen in 3D, and then you're going to want to ink each margin or surface. So on this one, the pleura is inked in orange, and so the pleura is the exterior of the lung. And then I have the surgical margin, so where the surgeon physically cut it out of the lung, is inked in green. And so there was probably a staple that was right there and we took it off. And then once we're measured and we've inked everything and everything's dried, we can serially section the entire specimen and look for that tumor. Once you see the tumor, you want to measure it in 3D and describe it. So how big is it? What's the shape of it? Is it ill-defined? Is it pretty, circumscribed? Is it white? Is it gray? Is it necrotic? And then, or texture, is it caseating? And then you're going to want to measure that tumor to both the nearest pleural surface, so the nearest point of it to the orange, and then the nearest surgical margin, so the nearest point from tumor to surgical margin. Whenever you're submitting sections of tumor, however big your tumor is, that's how many sections per centimeter you're going to want of lesion. So if you have a 2 centimeter lesion, you're going to want at least 2 sections of it. And then for a pneumonectomy, a lobectomy, and segmentectomy, it really depends if you're going to get the hilar structures or not, but I'll just say this as if it were a pneumonectomy. If you're getting a whole lung, you're going to need to orient yourself. So typically the requisition paper is going to say if it's a right or a left lung, but it's always good to double check. You can do this either by looking at the lobes. So if you have 3 lobes, it's probably a right lung. If you have 2 lobes, it's probably a left. But a more accurate and a good way is that by this little mnemonic called RALS, R-A-L-S, and I have 2 pictures up here of that. So it basically means where your pulmonary artery is in relation to your primary bronchus, which is kind of a mouthful, but it'll make sense. So RA, your pulmonary artery is going to be anterior to your primary bronchus on the right lung, RA. And then on the left lung, your pulmonary artery is going to be superior to your primary bronchus on the left lung, so LS. So orient it, measure it in 3D, If you palpate any lesion, you're going to want to ink on the pleural surface right over that lesion. That way you can measure the lesion to the ink once you cut it open. And then you're going to also want to take your margins of the hilar structure. So once you are able to figure out, which one's your pulmonary artery, which one's your pulmonary vein, and which one's your primary bronchus, you're going to want to shave those. You don't necessarily have to ink them because the pathologist should be able to figure out if it's vein versus artery versus bronchus in an H&E, but it doesn't hurt if you want to ink them differentially. Then you're going to want to describe the outside pleural surface. So is there anthracosis? That's common with smokers, and that's just like that dark little like pigmentation that is on the outside of the lung. Are there bullae? Are there little cysts? Are there areas of, caving in? And then you're going to want to start to look for any lymph nodes. So they'll typically tell you, I guess, if lymph nodes are attached in the specimen, but it's good to just take a quick look and see if you see any hyaline lymph nodes attached to any parts of the lung. So you'll section and submit those entirely. Then you're going to want to put a probe down the primary bronchus, and you're going to want to put the probe towards where the tumor is. So if you know the tumor is in the top part of the apex, then you're going to want to probe up that way. If you know that the tumor is, at the bottom part of the base, then you're going to want to put your probe down that way. And the whole point of the probe is so that you can cut along the bronchus, and that way when you open it, you can see if there's direct tumor extension into the bronchus. Once you open it and you can see if there's tumor in there or not, then you can serially section the entire lung specimen from apex to base. Once you visualize the tumor, you want to measure it in 3D and measure the distance of tumor to both the pleural surface and to each hilar margin. Again, you want at least 1 section per centimeter of greatest dimension of tumor. So for example, if you have a 4.7 centimeter tumor, you should have 5 sections. Also, it is really important for these type of cancers, if you do see lesion invading into the bronchus, to note that in your dictation because it automatically upstages the cancer. Histologic presentation. So since you're with squamous cell carcinoma, the histology of it is squamous pearl formation, keratin production, and intercellular bridging. So you'll have like little islands of abnormal keratinization within the epithelial pearls, and then there'll be like little whorls of malignant cells with some keratin in the center. So survival for squamous cell carcinoma of the lung, typically it's not found until the disease has spread, unfortunately, so there is a poor prognosis. It doesn't respond well to chemo and radiation, but again, the chemo and radiation can be used to help with pain, to help with some of the symptoms, to prolong life a little bit, but the 5-year survival rate is about 16%. It has increased. The 5-year survival rate in the 1970s was 10 to 12%, so it has gone up a little bit. There's a higher chance for a higher survival rate if it is detected early and treated. However, if the patient does have other lung conditions or comorbidities like COPD, emphysema, maybe like some heart failure, it is going to decrease the 5-year survival rate. One of the things that I didn't really think about and I didn't know about, so I have a lot of family members that smoke, unfortunately, is that the U.S. Preventative Service Task Force has recommended annual screenings for any patients that have been smoking for at least 15 years, but the criteria specifically is adults age 55 to 80 years old and have had a 30 pack year smoking history. So pack years is calculated by multiplying the number of cigarettes smoked per day and the number of years that you have smoked. And then with that criteria, you need to have currently smoked or have quit within the past 15 years and are healthy enough to go undergo lung cancer surgery. So thanks for coming to my talk. I hope that this kind of push anybody who does smoke or knows someone that smokes to, make those changes to have a healthier lifestyle. And these are my references. And thank you so much.